Today's presentation is about 4D cancer detection through medical imaging modalities. We'll begin by looking at an overview of cancer and then 4D image detection of cancer. We'll start our presentation by answering the question, what is cancer? Cancer begins as an abnormal cell growth or neoplasia. This abnormal cell growth or tumor can either be benign or malignant. The malignant or cancerous tumor is characterized by rapid growth, it invades and destroys surrounding tissues, and it will metastasize. Metastasis occurs when the malignant tumors spread throughout the body. Cancer begins in the DNA of the nucleus of a cell. The DNA is damaged and mutates. The four major causes of mutation of the nucleus are the virus, bacteria, chemicals, and ionizing radiation. When normal cells mutate, they become oncogenes. Tumor suppressor genes repair DNA, control the cell cycle, and cell death. Inactivation of the tumor suppressor, or the normal cell being changed to an oncogene, means that we have a cancer. This graphic was created in 2017 and shows the major types of cancers in both males and females. Note lung cancer is the #1 cause of deaths in both. There are four major classifications of cancers: carcinomas, sarcomas, lymphomas, and leukemias. Here we see the normal death and replication of cells. Cells duplicate through a process called mitosis. During this process, a cell's DNA can be damaged. This in turn can cause a mutation. The mutation can be repaired, or it can exist and duplicate in daughter cells. Replication of mutated cells results in atypical cells. The growth of the atypical cells results in a tumor. A tumor or neoplasm can either be benign or malignant. Here we have cell replication without cell death. As the tumor grows, it will eventually get large enough to become either benign or malignant. Benign tumors grow and displace tissue. Malignant tumors invade and destroy neighboring tissue. Once the tumor grows large enough, it requires a blood supply to continue growing, and it creates its own blood supply called angiogenesis. Tumors require blood to grow. Cancer cells spread through the bloodstream and the lymphatic system, or metastasize. Although the cancer cell remains the same, it will now lodge in new tissue. Metastasis. Cancerous cells travel via the bloodstream and the lymphatic system. The lymphatic system is part of our body's immune system, which helps destroy cancer cells. 1 out of 2 men will get cancer in their lifetime, and 1 out of 3 women. During cancer treatment, we try to boost the immune system to destroy cancer cells. Most cancer cells are destroyed by the immune system. For those cells that are not destroyed by the immune system, we have 3 methods of treating cancer. We can excise the cancer's tissues through surgery, or we can irradiate and kill the cells with radiation therapy. And finally, we can use chemotherapy to help kill those cells that are metastasizing through our body. Each of these is a standalone treatment, or they can be used in combination. Let's take a look at how the primary tumor spreads. The primary tumor, or where the tumor originates, is the type of cancer that spreads. It goes to other organs within the body. So a primary lung tumor can spread to the other lung, the bone, the brain, and the liver. Here we see the primary tumor and the crucial blood supply. The tumor is growing, and now cells break off from the tumor, go into the bloodstream. Now they are invading tissue. Part of the immune system, or the phagocytes or macrophages, come in and actually destroy some of these tissues. But some of the cancer cells may actually go to another portion of the body, embed in the tissue of that body, and then remain dormant until activated, causing cancer in the new area. This new tumor may be in a different organ, but still remains the same type of primary tumor, such as colon cancer can spread throughout the body, and when it's in a different organ, it is still colon cancer. Here we see the colon cancer cells. They are now activated and create a new tumor within the liver, and the process starts over. As we discussed, there are 4 primary types of cancer tumors. The first is carcinoma. Carcinoma is a type of cancer that develops from the epithelial cells. Specifically, a carcinoma is a cancer that begins in a tissue that lines the inner or outer surfaces of the body. A sarcoma is a cancer that is of mesenchymal origin. Commonly, sarcomas are found in blood vessels, bone, nerves, muscles, and tendons. There are many types of lymphoma. Lymphoma, or cancer of the lymphatic system, involves the lymphocytes or cells of the immune system. Leukemia is a group of cancers that usually begin in the bone marrow and result in abnormal white blood cells. These white blood cells are not fully developed and are called blast or leukemia cells. Cancer arises from the mutation of a normal gene, or an oncogene. It's believed that several mutations are needed to occur for a cancer to arise. Here we see the mutation process. In our DNA, we have normal genes, and when they turn cancerous, we have oncogenes. We also have tumor suppressor genes. Tumor suppressor genes control cell growth. Once the cancer cells break through the epithelial tissue's basement membrane, we have an invasive cancer. Prior to that, they are called cancer in situ. In situ cancerous cells are not considered to be cancer. It is once they invade that we have a cancer. What makes most tumors so lethal is their ability to metastasize. Most cancer cells will be destroyed in either the blood system or the lymphatic system. If some survive and are seated in different organs, they are now called metastasized cells. These metastasized cells can form a secondary tumor. Approximately 90 to 95% of all cancers are sporadic, and only 5 to 10% are inherited. Next, we'll look at how cancer can be visualized using 4D PET-CT and 4D PET-MRI. We'll discuss cancer and radiation therapy planning. We'll look at positron emission tomography and the hybrid imagers 4D PET-CT and 4D PET-MRI. At this time, 4D PET-MRI is a newer modality. We'll look at the relationship between 4D imaging, radiology or medical imaging, and radiation therapy and therapy treatment planning. We'll examine the relationship between the oncologist and the radiologist and 4D imaging. The overall objective of medical imaging is to acquire useful information about physiological processes or organs of the body by using external or internal sources of energy. For example, we use ionizing radiation, we use sound waves for ultrasound, we use radio frequencies for MRI, and we use gamma radiation for nuclear medicine. We use imaging modalities and the energies that they produce to interact with the tissue of the body to create data for medical imaging. Most major imaging modalities have been augmented with 4D capabilities to enable motion assessment over the respiratory site. 4D medical imaging involves the creation of 3D medical imaging and combining those 3D images over a time period. This allows us to see anatomy and physiology in motion. When imaging cancer for oncology, we use a hybrid system using PET-CT, SPECT-CT, and PET-MRI to produce images that we can utilize that show both anatomy, physiology, and motion. These hybrid images are used for integration into radiation therapy planning. In total, we use a combination of anatomic, functional, hybrid, and molecular imaging to battle cancer. Visually, 1D is when we draw a straight line or go between 2 points or coordinates. 2D gives us height and width. And 3D provides an image that gives us height, width, and depth. As human beings, we normally perceive our surroundings visually in 3D. Each of these dimensions is considered a geometric dimension. When we speak of 4D in medical imaging, we're not talking about more geometric dimensions. What we're talking about is adding the dimension of time to three-dimensional images. 4D is not really a visualization of a fourth plane, but a combination of 3D images over time. 4D images that are acquired at multiple times can be combined to give us sort of a cine look. Throughout the ages, images have evolved from two-dimensional to three-dimensional for a more realistic view, as 3D is how we perceive the world. 4D CT uses a new technology that captures the location and movement of your tumor and the movement of your body's organs over time. The term 2D and 3D are used to indicate dimensions. A dimension is any measurable spatial extent, such as length, breadth, and height. Essentially, dimensions indicate any and all sides of an object, such as the height and width, which allows us to measure them. The post-processing of 3D images for computers is a young technology in medical imaging. Further technological developments are likely to result in improved image quality in applications such as 4D, which we are experiencing now. In exploring 4D imaging, we begin by looking at digital image creation and the dimensions 2D versus 3D. The basis for 3D and 4D imaging is that once a data set of images exists in a computer memory as a solid block of data, it is possible to visualize that data from any angle and in 3 dimensions as well as 2 dimensions. In mathematics and physics, 2D is defined as having 2 axes to plot. Usually the axes are the y and x-axis. These axes are indicative of 2 aspects on the same plane, which can be plotted on the Cartesian coordinate system. Similarly, 3D indicates 3 aspects, which are plotted on the x-axis, the y-axis, and the z-axis. Here we have a table that shows a comparison between 3D and 2D images. We can look at the full form, the definition, representation, the mathematics, the aspects of the 2 and 3D, and the geometry of 2 and 3D. When we have a 2D image, everything on the image is superimposed. But when we have a 3D image, we are better able to visualize the body planes. A 3D image is a pixel-by-pixel map of the X-ray beam attenuation in the volume of collected data, or the voxel, as displayed on a matrix. Let's see if we can simplify this a bit. The advantage of the digital information we use in medical imaging is that the data we collect, we know each location and the nature of the digital level, and these can be adjusted. This allows us to post-process or manipulate the data to visualize it in many ways. One principal characteristic of digital imaging modalities is the drastic increase not only in the number of images they produce, but in the amount of data per image. First, we need to understand what a pixel is. Pixel is a contraction for picture element. A pixel has no dimension. It occupies no area, and it can't be seen, but it can have a coordinate. Pixels are demonstrated on a two-dimensional matrix grid. If we were to change this two-dimensional grid to a three-dimensional grid, the area taken by the pixel would be now a voxel, which shows depth. In either case, the pixel or the voxel is a representation of the data we collected for that specific coordinate. Here we see a matrix of densities that shows the Cartesian coordinates in which they were recorded. This is a column. A digital radiographic image is formed as an electronic image that is displayed on a grid called the matrix. The image is laid out in rows and columns. Here we see a row, so we see rows and columns. Here the row and columns are numbered to represent intensities captured. These intensities are selected to create our image. The intensities that are collected and used to make images can be collected from a 2D pixel or a 3D voxel. A voxel is the region surrounding the data sample. The third dimension depth can now be factored into the brightness for the 2D image display. In a 2D image, the different pixels are made up of shades of gray to create the image. In a 3D image, we have the voxel, which the intensities inside of the pixel itself change with the depth. By taking a matrix image and filling in the areas that connect between each one of the pixels by interpolating the shades of gray or averaging them out, we create a slice. We next stack the slices and interpolate the shades of gray between each one of the slices, creating a solid block of data, or a solid block of data that we can look at in 3 dimensions or any angle. This graph shows how data points are sampled within the voxel. Here we see the cube shape of the voxel, and here we see the data point. The voxel does not have just one data point, but many data points that represent the intensities that were recorded within this 3-dimensional space. Here's a representation of the data that is captured within the voxel and the amount of data that can be shown. 4D is comprised of 3D voxels that are captured and stored within the same coordinate. Multiple densities are recorded within the 3D space in the matrix. A histogram is a 2-dimensional bar graph of the intensities recorded. As we've discussed, in our voxel, what we're recording is intensities in 3 dimensions, the X, Y, and Z coordinate, or height, width, and depth. When we select the data, we can create all kinds of images. Here we see our maximum intensity projection, are 4D CT and a Fuse PET CT. We can select the data and the times that the data was being collected, and putting those together we can get motion images. We can post-process the data in a myriad of ways and create a number of types of images that we wish to visualize. Here we have two different views of the heart and the lung. We also see that they are in motion. We've rotated one of the images to show you that we can show depth as well as a two-dimensional image. At the bottom left, you'll note a histogram. Remember, a histogram is a graph of the densities that we have recorded and their position. These images represent the current data selected. Watch what happens when we change the selection of data. Not only can we change the selection of data, we can post-process the data within our selections any way that we wish. We can take these images and then we can combine them with positron emission tomography images to create a hybrid image that will show us not only the anatomy, but the physiology as well. In addition to being able to recognize anatomy and physiology, we must really understand how to manipulate our software to post-process images. Image processing and analysis methods are aimed at the enhancement of diagnostic information to improve manual or computer-assisted interpretation of medical images. We must know the modality or the modalities that are being utilized and how they record information to best optimize our imaging to create anatomy and physiology images in 4D. The instrumentation used in collecting data is one of the most important factors defining the image quality in terms of signal-to-noise ratio, resolution, and the ability to show diagnostic information. Our computer software takes the intensities that we've recorded on the modality and through lookup tables changes those intensities into colors or shades of gray to create images. The raw data is converted into a digital information that is stored inside of the computer in its memory. The signals that are created are stored in the computer in what is called K-space. To store and reconstruct a digital image composed of pixels or voxels, you need to know the value of each and its position in the image matrix. We generally use two-dimensional imaging for localization and real-time anatomical updates and verification of anatomy. 3D imaging and 4D imaging consist of axial, coronal, sagittal, and oblique slice data, which gives you an expanded view of your patient's anatomy and physiology. By demonstrating three-dimensional images with time, we have a four-dimensional image. Let's review once more creating a voxel from stacked matrix slices. Each image or slice in a given data set is made up of a number of picture elements or pixels. Just like we used to do with linear tomography, by having slices we can represent different depths that are superimposed on a regular two-dimensional image. Multiple 2D slices are acquired prior to creating a 3D image. This allows us to show depth. Processing a volumetric dataset begins by stacking the slices of a given dataset in computer memory according to the inner pixel and inner slice distances so that the data exists in a virtual coordinate space which actually reflects the real-world dimensions of the originally sampled volume. Voxel processing is a means of visualizing three-dimensional shapes and structures implied by a series of cross-sectional images. Our final section of this presentation will concentrate on positron emission tomography, MRI, and CT, and putting these images together for for four-dimensional imaging. Here we see a static PET image compared to a 4D PET image. The 4D image is the 3D image with motion. Here we see a PET CT scanner. How do we deal with motion, breathing motion or patient motion, when we do a 4D image? Here you can see an older version where we use gating, or we combine the respiration with how we capture the image. By recording the respirations and coordinating those with the images, we can actually make an image without any blurring motion from the respiration. This synchronization allows us to create hybrid images, where we superimpose one type of image with another. Here we see the anatomy from the CT and the physiology from the PET. We can combine 4D imaging with 4D radiation therapy planning, thus using less radiation to optimize the treatment of the patient. In this positron emission tomography image, we can see how the radionuclide, as it courses through the body, is attenuated, demonstrating physiology. Positron emission tomography is a study that is used in nuclear medicine to show tissue function. Although we can identify anatomy, the information about capillary blood flow, glucose metabolism or the metabolism of sugar, fluoride utilization, amino acid utilization, or other physiological parameters that characterize this tissue function are demonstrated with PET or PET scans. As we're looking at the function of tissue, we can utilize this system to evaluate cancer. Here we see images of a pre-treatment for cancer and a post-treatment for cancer. Notice the difference in the amount of activity between the two images. PET scanning is highly sensitive and specific, and we can visualize cancer in its very, very early stages, as well as taking a look at how we're treating the cancer pre and post treatment. The rotating image on the right demonstrates metastatic cancer throughout the body. Diagnosis, staging, treatment planning, therapeutic monitoring, and post-treatment surveillance are the key processes involved in evaluation of cancer patients and to determine the most appropriate management method for treating the cancer. Cancerous tissue readily demonstrates on positron emission tomography imaging. We can use positron imaging to scan the heart. It is a test that uses a radioactive substance called a tracer to look for disease in poor blood flow in the heart. Unlike MRI and CT, which reveal the structure of the blood flow to and from organs, a PET scan gives more information about how organs and the tissues are working. With PET scans, we can see the activity of the blood through the heart and the heart, but with respiratory motion, it becomes difficult. Let's take a look at a hybrid or a fusion image, the PET CT of the chest. We'll begin by looking at the physiology as demonstrated on the PET scan. Next, let's look at the anatomy using a CT scan, and we can correlate the two. This is called a hybrid or a fusion image, using both the CT and the PET scan in conjunction with each other. Notice how we can see both anatomy and physiology in the hybrid image. As you can see, we begin with the PET scan and then the CT scan, and then combine them both into a singular image. These images show a cancer in the salivary gland, and next to the image of the cancer in the salivary gland, we can take a look at the whole body image in a PET scan. Now let's have you take a look at some images and see if you can see the tumors. Here it stands out more brightly. Here we take a look at a complete body PET-CT fusion image. Now let's take a look at the process for doing a 4D radiation therapy treatment plan. 4D medical imaging has become a powerful technique for correcting motion artifacts, studying internal organ motion, and providing temporal volumetric images for using 4D imaging for radiation therapy planning has some advantages. First of all, you get a motion-free PET image for accurate diagnosis. Next, you get a motion-free intrinsic PET-CT image which registers the accurate position or localization of the tumor. And finally, you get a motion-free PET attenuation for accurate metabolic activity assessment and tumor volume delineation. Hybrid imaging is combining images from different modalities so to demonstrate different aspects of a patient's pathology, disease, and anatomy. 4D images are created from solid blocks of data, which are formed from combining the slices taken during a scan. To create a 3D slice, we need a slice that has information from all three angles, axial, sagittal, and coronal, to be combined. We then stack these slices to create a solid block of data to draw information from. Using the computer, we can select data from any direction to be able to demonstrate the areas of interest. Imaging modalities that have digital data and computer-driven algorithms can create time-resolved volumetric imaging, or a data block of imaging which we utilized for 4D because we're seeing 3D images over a period of time. This includes CT, PET, MRI, ultrasound, SPECT, single proton emission computed tomography, and hybrid systems like PET-CT and PET-MRI. Let's create a 4D image. To begin, we acquire slices in each one of the body plane directions, axial, sagittal, and coronal. We create a volumetric data set for each one of these slices, the axial, sagittal, and coronal, which allows us to create 3D images. Combining or binning this data to reflect the coordinates it was collected in and the time it was collected in, we're able to create 4D images. When creating a 4D image, we need to synchronize the images to eliminate those areas that have motion due to respiration. Here we can see the coordination or the synchronizing of images. Now let's look at the process in its entirety. Once the data has been acquired, we're able to post-process or manipulate the data. We select the data that we wish to manipulate by choosing the data utilizing a histogram, which is a recording of the intensities that were acquired during imaging. We can both window and level the data to create different types of images and different intensities. We need to track the motion. Motion tracking acquires image projections continuously with an associated timestamp that indicates the respiratory phases. We now have 3 blocks of data, axial, sagittal, and coronal, that are sequenced as far as timing, and they're co-registered. Let's use 4D CT as an example. The table starts stationary and then it moves to the next phase or position, and then the cycle repeats. Information is gathered for each phase and combined to construct an image that represents the location of the anatomy at that precise moment. We acquire images using computer gating. In other words, we take the images based upon the patient's respiration. The modality gets a signal on the respiratory phase for each patient and acquires an image according to the signals received. Once the data has been acquired, we can bin the data. Binning is the process of combining pixels together to make superpixels. Another way to look at this is we take the data at each timestamp and from each of the planes and coordinate it or put it into a bin for selection. Remember, the imaging matrix is comprised of different positions that are coordinates that register the intensities at those coordinates. The voxels contain 3D images that are time-stamped. 4D images reflect data that is obtained or acquired simultaneously over a period of time. There are two types of binning or sorting. One is phase binning and the other is amplitude binning. In the phase binning, each breathing cycle within the images are grouped. In the amplitude binning, the images are assigned bins according to the breathing signal's full amplitude. Let's take a look at positron emission tomography, which demonstrates physiology. This is a nuclear medicine study using FDG-18 contrast to inject into the patient. FDG is a contrast media made up of fluorine, oxygen, and glucose. We inject this radioactive contrast media into the patient's bloodstream. The patient metabolizes the contrast, and remember, glucose is sugar, and we use sugar for energy, and since we have rapidly dividing cells in a malignant tumor, it eats a lot of sugar. Cancer is known as a sugar eater. This radiotracer accumulates in body tissues with a high energy demand, especially tumors. Here we see the radiotracer in the bloodstream. Fluorodeoxyglucose moves from the blood vessels into the surrounding tumor tissues. The fluorine 18 atom decays within the tumor cell, emitting a positron. These positrons react with nearby electrons in an annihilation reaction, producing a pair of gamma rays in opposite directions, 180 degrees apart. These gamma rays interact with the tissues, creating data which is recorded in the PET scanner. 4D PET-CT captures the movement of organs and tumor over time, while also recording the metabolism of the tumor. It creates the most complete and accurate imaging data on the tumor and critical organs. After acquisition, we post-process the imagery. Areas of tumor tissue can be seen on the PET scan. Software for imaging techniques have the potential to compress large quantities of data into a single image, as well as provide new measures currently not used for diagnosis, such as rates of change. Positron emission tomography, or PET, is a three-dimensional imaging technique designed to measure the level of metabolic activity within a cell. Positron emission tomography, or PET, identifies biochemical activity in addition to structural tissues. A gamma-emitting radiotracer is injected into the patient. This radiotracer is allowed to circulate throughout the system prior to taking the images using a positron emission tomography system. Basic three-dimensional medical imaging acquisition and reconstruction principles are based on the assumption that the object being imaged is static or not moving over the course of the acquisition. Of course, if the object is moving, we have to go ahead and take some measures to eliminate the motion. Imaging moving anatomy results in the presence of artifacts in the reconstructed image. Artifacts, the specific appearance of which is dependent on the image modality, can impact on the diagnosis because of blurring of the object boundary or decrease in resolution or image noise. Across all modalities that utilize 4D imaging, there are two strategies to counteract motion. The first strategy is continuous acquisition, in which the entire anatomy of interest is continually acquired as the patient breathes. The second major type of acquisition requires partial images, reconstructed slices or partial sets of projections from separate breathing cycles to be combined into a full volumetric image representing a breathing state. In 4D imaging, what we find is that the movement of the tumor, which is caused by respiratory displacement, leads to the expansion of the delivery range in treatment planning for radiation therapy or the degradation of the accuracy of the position in the treatment. In the image diagnosis, it also generates CT image artifacts and PET image blur, which affect the reliability of the acquired image. Let's compare these two images. Which image would give you a better quality diagnosis, and which image might you have to use more radiation to cover the tumor? Let's get rid of that blurry image. Prior to the technological changes we've recently seen with PET MRI and PET CT, we used to use a respiratory gating system to counteract motion. Newer PET CTs and PET MRIs use an automated system, and they do not use the externally mounted respiratory gating systems that we have used in the past. These new systems are more compatible with the 4D radiation therapy planning programs. Let's look at an older externally mounted system used for respiratory gating. This system uses a target in the area of respiration, and it records the respirations using a UV signal from a motion cine light. The continuous respiratory motion is recorded, and it is then synchronized with the system to create images that have the motion subtracted from them. We select those images that are in the same phase to synchronize. Final image minimum blur. The newer 4D CT scanners have therapy planning software for radiation oncology built within the program. This takes away a lot of the time that was utilized in trying to sync the images together from two different areas, and at the same time it gives you more accurate and precise images. This also helps when you're planning and doing radiation therapy. The more precise image gives the radiation therapy unit a smaller target, so there's going to be less tissue that's exposed, and it is also so in sync with the motion of the tumor in an area that's got respiration, like the chest and abdomen, that you're not overshooting the area, that you're hitting it exactly where you should with the IMRT, or intermittent modulated radiation therapy equipment. As technology evolves, PET-CT is giving way to PET-MRI. We're just at the beginning of PET-MRI, so we'll take a look at PET-MRI in our next segment. Radiation therapy is using 4D and 3D conformal radiation therapy and intensity modulated radiation therapy for treatment of cancers. The more precise the information they have in their planning, the more accurate their treatments are, and the less tissue becomes irradiated. Remember, our goal is to kill the cancer tissues and not the surrounding tissues. As they say, one picture is worth 1,000 words. So let's take a look at this PET-CT versus a PET-MRI for the same area, which is going to be in the chest and abdomen where there's going to be motion. Which of these two images would provide the most accurate information for the radiation therapy planning? Obviously, it's the MRI. Presently, it's easier to acquire images with a PET-CT than a PET-MRI. But as the technology improves, we're going to see an evolution from PET-CT to PET-MRI. We can see on this therapy plan how much better the tumor is visualized on MRI than it is on CT, and how much more accurate we're able to actually utilize our radiation therapy targeting the tumor. Fundamentally, MRI was developed to demonstrate tissues, and it is much more accurate than using ionizing radiation and a CT scanner in demonstrating the different tissues within the body. MRI PET reveals both the anatomical and physiological characteristics of the cancerous disease. Here we see two of the newer generation PET MRIs. One is Siemens and one is General Electric. Early versions of PET MRI had one table that was shared between a PET scanner and an MRI scanner. Today, the PET scanner is incorporated into the MRI itself. And here we can see the different gradients and in the MRI, and also the detection ring for the PET scanner within the system. Integrating the systems gives us more accurate and precise imaging. The patient is always at the correct position, whether being recorded with the PET scan or the MRI scan. Here we see a full body PET MRI, and notice by focusing in on each section of the MRI, we still get accurate images, whether it's the liver, the lungs, or the brain. In the future, MRI will probably be the modality of choice for radiation therapy planning and PET. What we're looking at here is by having more accurate images, we're using less radiation, not only in the fact that we're able to precisely target the tumors, we don't have to use the CT scanner's radiation to add to the radiation that we're being provided for in therapy. It is much more difficult to design an algorithm and acquisition technique for MRI to combat motion than it is for a CT scanner. With MRI, if we want a maximum intensity projection reconstruction, we're going to have to wait while the contrast builds up to its maximum intensity. This requires us to get a slow acquisition, and we have more problems with the obvious motion. We can get rid of some of the motion using our external or triggered 4D gating system. We can also use fast and ultra-fast techniques to acquire the images and then use a retrospective technique. In other words, going back in and subtracting out images to get a better quality image. Here we can look at the difference between an image that's taken normally and one that we've gone back in and subtracted out data. On this image we can see a Cigna PET MRI time of flight image. And then when we go back and take out some of the data, we can actually clear up the image, making a better and more accurate image to diagnose and to treat with. By subtracting out data, we can reduce noise and see the image more clearly. Also, by subtracting out data, the image of the tumor becomes more conspicuous, or the tumor becomes more conspicuous in the image. Deviceless 4D calculates a patient's breathing cycle length prior to the CT simulation. It automates the sorting of the 4D CT images into the desired respiratory bins and creates intensity projection databases and makes them available for virtual simulation. Let's take a quick look at this radiation therapy planning solution. Let's take a look at the process. First, we get the CT scan and localize the tumor. Then we put on reference marks for treatment planning. Then we do a virtual simulation. After the virtual simulation, we finalize by doing the actual radiation therapy treatment. In 90% of the PET-CT oncology cases, disease is located in the chest or abdomen. These areas are subject to respiratory motion, which can displace organs and lesions by a range of 5 millimeters to 30 millimeters, blurring the images and reducing the diagnostic confidence. OncoFreeze is software that uses the chest image as a reference and employs an optical flow diagram to de-blur the static image until it matches the high-density chest image, using 100% of the information. This software and system works with the chest analysis of each patient's breathing pattern, and it identifies the portion of the respiratory cycle with the least motion. This portion of the cycle is where most of the data can be collected with the least amount of respiratory motion. This is a deviceless, automated respiratory gating system designed to address the problems of image blur. OncoFreeze provides images virtually free of respiratory motion in the same time as a regular whole-body scan. It helps improve delineation and quantification of small lesions, which increases the physician's confidence in treating. It adapts to each individual's unique breathing pattern to deliver the best possible image. We've looked at 4D imaging and how 4D images are created. We did a specific focus on utilizing 4D imaging to capture cancer images and utilize those images for radiation therapy planning. Our focus has been on PET-MR, PET-CT, and 4D radiation therapy planning. So it's time to thank you for your time and your attention. And I'd like to say thank you again, and this is Mark Struthers.